Hey guys, welcome back to another video. So in this video, I want to discuss the pharmacological management of hypertension. So before we jump straight into the actual drugs themselves, I just want to cover just a bit of a background. So with hypertension, you're talking about an elevated blood pressure measurement that you take on 3 separate occasions with a minimum of them being 2 days apart. So just in terms of the classification of hypertension, so you can either be dealing with primary hypertension. Another name for that is essential hypertension, and it's usually got to do with the family history. There's also other factors like obesity and also just some fetal factors as well. Also, alcohol and the amount of diet issues can also contribute to essential or primary hypertension. But the other class of hypertension is secondary hypertension. So with secondary hypertension, you usually have a specific cause that's causing hypertension. So yeah, I won't go into details with that. But yeah, just to move on to the actual drugs themselves. So obviously with pharmacology, our first choice is always to use non-drug measures. So when I say non-drug measures, I mean like stuff like lifestyle modification. So whether that being exercising regularly, changing the diet, trying to reduce that BMI, also just like alcohol consumption or smoking, trying to reduce that. That's obviously your first line. And if there are changes that take place with those things and you're still not seeing the results that you want, that's the stage where you want to consider actual pharmacological management, because the reality is with the use of any sort of drug, there's always going to be some sort of adverse effect. There's never going to be a case where it's always going to be perfect and there's only positives. There will always be side effects that there is a risk that'll happen. So that's exactly why you want to try and leave pharmacological measures to be your last option. So let's jump straight into the actual drugs themselves. So the first class of antihypertensive drugs that you need to be aware of is your diuretics. So with diuretics, don't worry about these photos as yet. I'll zoom in when I need to explain anything on those photos. But for now, so with diuretics, so let me just write it down. Diuretics, okay. So with diuretics, what you're trying to do basically is reduce the volume of blood. That's the fluid volume that's happening with this patient. It's usually very overloaded in these cases. And by reducing the fluid volume, you're going to reduce the blood pressure, okay? So there's 3 main classes of diuretics. So your first class is your thiazide diuretics, okay? So your thiazide diuretics, a common name for a thiazide diuretics is your hydrochlorothiazide, okay? After that, you have loop diuretics. So loop diuretics, and the final one is potassium sparing diuretics. Okay, so it's very important to understand this concept of low ceiling and high ceiling diuretics. So I just want to zoom into this picture here, right? So on this graph, you can see this thiazide depicted here, right? So if we look into this a bit closer, we can see that as the dose is increasing, the amount of sodium chloride excreted, or basically the effect, is remaining stagnant after a certain amount of time, right? So that's known as a low ceiling diuretic, okay? So the catch here is, even though you're increasing the dose, your response is tapering out and stagnating at a certain point. But as you keep increasing that dose even further and further, you're increasing your chances of having an adverse drug reaction, right? So obviously it makes no sense to be giving high doses of something with a low ceiling diuretic such as thiazides, because you're not benefiting the patient in any way, but you're increasing their chances for adverse drug reactions. On the other hand, with something like a loop diuretic, so here a loop diuretic, it's known as a high ceiling diuretic, because as you increase the dose, you can see that there's actually a proportional response to the dose increase, right? So yes, while there might be adverse drug reactions with something like loop diuretics, you are seeing a change in effect that's matching that level of increase in the drug, unlike a thiazide diuretic, right? So just to give you some examples of some names of some of these drugs, so thiazide, so hydrochlorothiazide will be an example of that. With a loop diuretic, you're talking, so furosemide is a common example. Okay, and then with potassium sparing diuretic, common example would be spironolactone. Okay, so just bear in mind that I'm making this video from the perspective of a South African healthcare professional. So the drugs here are obviously drugs that would be used as sort of like first line or what's readily available in the public healthcare sector in South Africa. So depending on which part of the world you are from, these might vary. But the classes of the drugs are consistent regardless of where you are. Okay. And then obviously there's a further division of this in terms of when you're talking about brand names of drugs and stuff like that. But as long as you know the actual drug classes and the actual names here, then you should be fine. So just in terms of actually the mechanism of action of these drugs, so the difference in mechanism of action actually comes in. So if you look at your nephron, right? If you zoom into your nephron and say, okay, where are these drugs actually acting, and on in what way are they affecting the body, right? So let's look at loop diuretics. So remember, loop diuretics we said is our high seeding diuretic, right? So here we said there's a proportional relationship between your dose and your response, right? So here, if we look carefully, we can see that the loop diuretics is actually working on this is known as the sodium potassium 2 chloride exchange, right? And this is in your ascending limb of the loop of Henle. So this is a very potent, it has a very potent effect by acting on this exchanger, hence the difference in effect here. Whereas the thiazide, if you look here at your distal convoluted tubule, you can see that it's working on the sodium chloride channel. So that's what accounts for the difference here in low versus high seeding diuretics. So obviously, based on this information, just clinically speaking, if we've got a person that's quite severely fluid overloaded and we're going to diurese them, we obviously want to go for something like a loop diuretic, just because of the effect that we're going to get with that higher doses. We're going to get a proportional or somewhat of a proportional effect. Whereas if we gave a thiazide, we're going to be capped at this certain level of effect, and any increase in dose from there is not going to garner you the results that you want, and it's simply going to increase your chances of causing an adverse drug reaction in the patient, which we don't want. Okay, so now let's move on to the next class. So our next class of drugs is what we call the ACE inhibitors. Okay, so ACE inhibitor is angiotensin converting enzyme inhibitor, right? So if you remember our RAS system, or renin angiotensin aldosterone system, these drugs are going to basically prevent the conversion of angiotensin 1 to angiotensin 2, right? So it inhibits the enzyme that converts angiotensin 1 to angiotensin 2, okay? So in terms of some drug, example of an ACE inhibitor would be enalapril, okay? Enalapril. That's a common ACE inhibitor that is used. Okay, so sometimes there will be instances where you give a patient an ACE inhibitor and you don't get the response that you want on the ACE inhibitor. So you might have to resort to the next class of antihypertensive drugs that I'm going to talk about, which is angiotensin receptor blockers. So angiotensin. So it's actually angiotensin 2. So that works on angiotensin 2 receptor block. And clinicians usually shorten that to ARBs, right? So ARBs. This is a pretty self-explanatory one. So this drug is going to block the receptor that angiotensin 2 itself would be binding on, right? So a common example of this drug would be losartan. Okay, the next class of drugs we're going to talk about are calcium channel blockers. Okay. Channel blockers. So calcium channel blockers is basically it's going to prevent calcium from entering cells of the heart and blood vessel walls. which would in effect decrease your blood pressure. And so just a common example of this. So in the Philippines, sorry. Okay. And then, so there is a sub classification of calcium channel blockers. It's called dihydropyridines and non-dihydropyridines. Okay, I will talk about something in the next class of drugs that's very important to note. So just for the sake of time, the last class of antihypertensive drugs that you need to be aware of is what we call our sympatholytic agents, right? So sympatholytic agents. Okay, so the name sympatholytic, so where does that come from? So basically, the autonomic nervous system is divided into your sympathetic system and your parasympathetic system, right? So sympatholytic, right? So lytic means you blocking it, or you reversing it, or you breaking it down. Okay, so it's working against your sympathetic nervous system, right? So remember, the sympathetic nervous system in the body, what it's trying to do is it's always trying to increase your blood pressure. It's your fight or flight response, right? So you see a lion, you want to try and run away. All the effects that your body will undergo in order for you to successfully fulfill the flight or fight response would be due to the sympathetic nervous system, right? So based on that knowledge, we can then deduce that if we were blocking the sympathetic nervous system, usually by the use of a pharmacological method such as these sympatholytic agents, we are basically going to reduce our blood pressure, which we want in this case because we're trying to treat hypertension here, right? So just in terms of the drugs that we're talking about with here, so we've got centrally acting agents. So a common example of a centrally acting agent is methyl-dopa. And another agent in this category that I'm sure you might have heard of before is your beta blockers. Okay. So I just want to quickly mention, so I mentioned earlier the sub-classifications of calcium channel blockers being dihydropyridines and non-dihydropyridines, right? So a very important thing to note is you do not want to be administering beta blockers together with non-dihydropyridine calcium channel blockers. So that is a very dangerous thing. If you are going to administer a calcium channel blocker with a sympatholytic agent, you rather administer a dihydropyridine calcium channel blocker with a beta blocker, okay? So in order to understand this drug, so basically your autonomic nervous system, so ANS, okay, so if we're focusing on the sympathetic division, there's four receptors that you need to be aware of, right? So that'll be alpha 1, alpha 2, beta 1, and beta 2. Okay, so your drugs that are the sympatholytic agents, you're going to be affecting these receptors, right? So beta blockers, right? Beta blockers is going to block these beta 1 and beta 2 adrenergic receptors. So with beta 1, you basically are dealing with the heart. So beta 1, you're talking about inotropic and chronotropic effects, right? So a beta blocker is going to have a negative inotropic effect, okay? So very important to note. So with asthma patients, right? So asthma patients, we normally give them for short-acting treatment. Is your short-acting beta 2 agonists, right? So agonist meaning that it will stimulate that receptor, beta 2 agonist. So as one can understand, if you're dealing with an asthmatic patient that's also hypertensive, right? You obviously you're not going to want to give them a beta blocker because you're going to be blocking beta 2 adrenergic receptors. So you're going to antagonize it. But you don't want to do that because that's going to cause bronchoconstriction, right? In an asthmatic patient, the whole point is to keep those bronchi dilated, right? So that's one of the important contraindications to note, is not to give a beta blocker in an asthmatic patient, right? And so just with methyl-dopa, right? So methyl-dopa is a centrally acting agent. And interestingly enough, so alpha-2 is an interesting one because stimulation of alpha-2 actually inhibits or counteracts a sympathetic effect. So methyl-dopa basically works by agonizing alpha-2 receptors, which in effect will inhibit the sympathetic nervous system and lead to a reduction in blood pressure, and therefore as a form of treatment of hypertension. So this was just a quick overview of hypertension, the pharmacological management of hypertension as a whole. I tried to keep it as high yield as possible to give you the most important points that one would need either as a doctor or even just as a pharmacology major, as an introductory lecture. So I hope this helped you with your understanding of the concepts, and I think it's worthwhile to take this as a starter and build upon the knowledge that I've shared in this video. So thank you very much for your time, and I hope you stick around for our future videos. Have a great day.